And next coming up, we've got my co-founder, and trustee of ADHD, Dr. Max Davie, talking about non-pharmaceutical interventions for children with ADHD. He is he's a medical doctor, he's a paediatrician, and he is my long-term friend. I have known him a long time, longer than I cared probably to admit. Right, without further ado, hello, Max.
Hello, morning.
Good morning. You were frightening me then, because I was like, is he on mute? Like that quiet pause at the start. So tell me, like, what's it like being on the roller coaster of ADHD UK? We are both the co-founders, right? We've done this together.
I mean, it was a brilliant timing starting a small charity just before everything stopped. I mean, I thought that was, a masterstroke on both of our parts. Yeah, I mean, it's bit
because we started and then lockdown happened. Boom.
Yeah. Yeah, I mean, it's been, it's been a ride. We've all learned a lot, and I think we're just sort of I don't know, getting ourselves back on our feet again for the 5th or 6th time. But the thing is, every time you get back on your feet, you can do it. So you just do it again.
Yeah, it's and I think that's a testament to what we try very, very hard to hide, which is how hard this is, and the huge challenges of being a very small charity with a community of 2.6 million people with ADHD. And having to deal with terrible things. And I talked about it in my introduction, but we're having articles saying, "Does ADHD exist?" Having the deputy chairman of the Conservatives saying ADHD is bad parenting. You're just these battles that
it's constant. And I have to say, so publicly say, your determination in this has always massively impressed me. There have been moments when I'm like, I can't do this anymore. But you've always just plugged away. You've just kind of come up with something and got us and kept us going.
Yeah, thank you.
And so, that's an amazing thing.
Well, thank you very much. And certainly when I talk to other charities, and you watch when they people as they go through, it's happened with us, like the battle is just very wearing, and people, it's very wearing. Because not only when people are attacking, not only are they obviously trying to denigrate the whole of ADHD, but it's also undermining of each individual. It's undermining of me, of you, where they're just like, ADHD doesn't exist. Going back to them going, someone recently said, it's terrible. Some people making ADHD part of their identity. Like, duh. I didn't choose this.
You would never say it's terrible for somebody to make autism part of their identity. That would be a completely unacceptable thing to say. So I don't, or your
physical
sexuality
disability,
part of your
being
identity.
deaf.
I don't understand. Yeah, I don't understand why this is something that you can be prejudiced about with impunity. Well, I do understand it, but I don't think it's excusable.
It's no other condition gets this. It's just in the same way, as far as I can see.
I would.
There isn't a game of try and work out who's got it worse. Yeah. I'm not saying that others don't have it bad.
Well, I mean, personality disorders probably have it terribly badly.
That's a fair point. Okay, this isn't a competition. But yeah,
it's not a competition. But those guys really do.
No, I think there is a lot to be said there. Right, you've got to talk. You've got a whole.
I have got to talk.
A whole adventure of knowledge.
I didn't just nip on for a chat.
Oh, we could do this. Got an hour.
Yeah, it's
right.
fine.
Shall I put your slides up? You want to do it?
Yeah. I'm assuming someone's going to put the slides up for me. Wonderful. So, okay, do I do this? Is that going to work? Cool. All right. So I'm going to talk. I just Henry's introduced me. I think the thing I've got to sort of emphasize is that I am a perfectly ordinary NHS doctor serving. I'm gesturing towards the borough of Lambeth on my wall behind me. I work in Lambeth, and I work for the NHS, and so we sort of scrape by, basically. So when I talk about the non-pharmacological treatment of ADHD, I suppose I'm talking about, well, this is what I'm talking about. It's basically the person-centered treatment of ADHD, because in a sense, there's two things that you talk about when you talk about the treatment of ADHD. One is the treatment of the ADHD brain, and the other is the treatment of the ADHD person. And I think the evidence base, and I will talk quite a lot about evidence base in this talk, and I'll have a look at the comments if people aren't following, but the evidence base looks very different if you're looking at the brain to what you're looking at when you're looking at the person. And I think that's a really key point. So I'm not saying that, spoiler, it probably is the person, but I'm not saying that you could ignore the brain, but there's two different ways of looking at how you treat ADHD. And the answer to what the usefulness of non-pharmacological methods of treating ADHD depends on what the question is, as in, are you treating the brain or are you treating the person? So I will explain. I just do want to quickly think about medication quickly. If you focus on the brain, just focus on changing the brain, making the brain essentially less ADHD-ish, which is a technical term that we doctors like to talk about. It's not, you know what I mean, though. The whatever that X factor that defines ADHD, reducing that a little bit and making that a little bit easier to deal with. In terms of at a brain level, medication is effective. Does it reduce hyperactivity and impulsivity? It does improve concentration. We've got pretty good evidence for that at studies at a population level, and also if I'm starting medication for a patient, I'm pretty confident it's going to have that effect. I didn't use the word work because a drug doesn't necessarily work. A drug has an effect. Whether it works is depending on what you want to get out of it. Do you want to reduce your hyperactivity, impulsive, and poor concentration? Probably. But why do you want to do that? In order to make your life better. And that's the extra step that I think isn't measured necessarily in medical trials. Sometimes it is, sometimes it isn't. But if you're narrow about what counts as evidence, and you in terms of what you're measuring, as in just the performance of the brain, and you're kind of short in your duration of study, then medication is far and away beyond everything else. Okay, but this wouldn't be a great talk about non-medication management if that's all I had to say. But if you may take a person focus, two things happen. One is you have to be broader. A person is not just their brain. A person is not just their performance sitting in front of a TV screen, clicking or not clicking a space bar. The person is the whole person. I mean, obviously you've been sitting and watching this conference, and you don't need telling, but that has key implications for what treatment means, because actually, and we always talk about this being about being patient-centered in the NHS and in healthcare generally, but we get distracted by, let's just change your brain, let's just make you perform better at these particular discrete tasks, whereas actually what the person often comes to and with is, I want my life to be better. I want the impairment caused by whatever it is that's happening for me to be reduced. And so this key concept of impairment doesn't get talked about enough. And I think that's where the non-pharmacological aspects of managing ADHD really comes in. So this is a graph that takes a bit of explanation, but I always have it in my mind when I'm thinking about ADHD. So this is kind of ADHDness. I call it hungry brain. How hungry your brain is. It's a metaphor that I prefer for ADHD. Other people might say busy brain or fizzy brain. Doesn't really matter. How ADHD your brain is along this axis down here. And at some point you make a diagnosis. That's not important right now, but let's say you are here. So most people with ADHD, just mathematically, most people with ADHD are in this ballpark. A few people are in this ballpark, but only a small number, just by definition, because it's a normal distribution. If you are here, what are your options? Well, you can take some medication and that will nudge you in a more typical direction on this axis, and your impairment will go down a little bit. Okay, that's fine. You could do that. Or you could modify your environment. Now, this doesn't come from particular. This is mainly from my experience, and it's a mental model of how things actually work in the real world. There is evidence that some of the modifications do improve impairment, do reduce impairment, but it does need to be, and that's what the NICE guidance says, it needs to be a wrap round care, and it does decrease impairment. So what happens is basically you shift the curve a little bit, and if you think you're here and you reduce your, you modify your environment, look at how much impairment gets reduced without changing your ADHD at all. And then maybe you can try some medication and look where you are on the curve. A tiny change in your brain state will have a big effect on your impairment. So I think that's kind of really does underpin a lot of my approach, is just that little curve. So I think maybe I should have said before drugs instead of beyond drugs, but that doesn't sort of have such a ring to it. So what you get is you bring in all of these other things. You bring in gut health, you bring in exercise, you bring in mental health, you bring in all sorts of things. And then the question comes, well, what actually works at a person level and what works at a brain level? We can deal with that fairly quickly because not much does. What works at a personal level to help people with ADHD? And that's a very difficult question, because research on how much people's actual lives improve over long periods of time is really difficult to do accurately. The longer the period and the more broad the focus, the less quality the research becomes. And so that is very difficult when you're trying to assess evidence. That's just a point that underpins a lot of the debate about this. Okay, so this is whenever, almost all the time I make a diagnosis, I will kind of put my fingers up and say, I have a 5-point plan for you, because I think people feel, okay, he's got a plan. Good, we got a plan. But the plan is not just, I don't have the same plan for everything. These are just 5 points that I want to make. One is education and understanding, then brain health, then support at home, and wherever home is, support at either school. I don't do adult ADHD, but I've just put work in here, and medication. I think that's a reasonable 5-point plan. Medication is deliberately at the end of that plan for the reasons I've outlined. So education and understanding, I think it's often misunderstood that what you need, there's this phrase psychoeducation that's often used. It's used in the NICE guidance. People kind of bandy it around as what we need is more psychoeducation. Psychoeducation, first of all, is not just sitting there listening to things. I mean, maybe this talk is kind of psychoeducation and sort of, looking at slides of brain scans and nodding. That's not psychoeducation. Psychoeducation is a conversation. Psychoeducation is an understanding, taking what you understand now about the condition with somebody else and kind of refining and coming to a shared understanding. And psychoeducation can occur within a family. Discussion within a family can be psychoeducation. And I think there are 2, and for me, the education understanding is not about knowing what part of the brain is affected by ADHD. Spoilers, all of it, which is why brain scans are not that useful. It's about avoiding 2 sorts of attitudes and getting the right attitude at the beginning, right in the middle. So the attitude on the left of the slide is the kind of blaming attitude. And both of these attitudes are kind of extremes, and they're almost kind of, it's more that people think that other people hold them than actually anyone actually holds an extreme view of these. One is basically blaming the child, blaming the person. You just need to work harder. You're just being lazy. You just don't want to do it. You're just trying to hiding behind whatever it is that you think you have. Just get on with it. And obviously we've all had that experience, we've all had that person in our lives. That's something to avoid. The other extreme, of course, is what that person thinks you might be saying, which is, oh, I've got ADHD, so I can't do this. I've got ADHD, so I can't do homework. I've got ADHD, so I can't be at work on time. I got, all of those sorts of things. And what I always say, and this is such a basic thing, but actually I think it just has real power, is ADHD is a neurodevelopmental condition. I don't need to tell this audience what that is. A neurodevelopmental condition that makes some things more difficult, but nothing impossible. Nothing is impossible as a person with ADHD, but some things are very much more difficult and require much more support, mental energy, etc. And that's such a simple message, but actually the implications of that just spool out if you actually think about it, any particular situation in the context of that. And I know that's really basic, but people get it wrong so much. And we've seen this week with sort of comments from Lee Anderson, of the Deputy Chairman of the Conservative Party. He clearly doesn't get it, which is sort of not really okay, but he's not the only one. So the second thing is brain health. I'm not mad about the phrase brain health, but it does make sense to people, and it is quite kind of now, if that makes sense. These are the things that have a really good evidence base for optimizing these being good for to an extent, the brain, to an extent, the hyperactivity and impulsivity, to an extent, but also the overall well-being of a person with ADHD. So I'm going to talk about these in a little bit more detail. So when you think about exercise management, using exercise to manage ADHD, I think some people might have in their heads, oh, I have to do planking, or these sort of unnaturally cheerful people trying to plank. Yeah, it looks horrendous. But actually, what I think is much more important is just having an active life. I'm not mad about step count. I don't think 110,000 steps or whatever is a magic number at all. But keeping moving as much as you can is very helpful in the short term and in the longer term for your mental health, partly because it helps you to sleep. So walking the dog, that's one of my kind of main bits of, I don't walk the dog here, sadly, but it's one of my main bits of exercise. And I think that's what you need to focus on. You don't need to get a gym membership to get the exercise you need to manage your ADHD. Sleep. Now, people do get quite hung up on the duration of sleep. Now, this is a graph for 14 to 17-year-olds. The same graph essentially can be drawn for any age of child and for adults. The point about the graph is that this is healthy volunteers. This is not people who have a problem. The amount of sleep that people get is really, really, really variable. And so you can, therefore, it's very, very difficult to say on the basis of an amount of sleep, that is not enough or that is too much. What you need to look at is the individual. Are they rested when they wake up? I mean, the thing I do ask about bedtime in clinic, but what I ask about, well, what is it like in the morning? Because if the child is bouncing out of bed at 6 in the morning and they only got to sleep at midnight, and they're not sleeping in the day, and they don't have a nap, and they're fine, they are at this end of the distribution. It's a pain because sometimes you've got to be up with them, but that is how they sleep. And so giving them sleep medication to get them to a magic 8 hours is a bit pointless. But if they're not rested, then you may have a problem. So then you've got the question is, what is the sleep consistent? Is the sleep pattern consistent? Sleep is a really ingrained habit of the brain, and it doesn't work properly unless it's ingrained and unless it's consistent, unless there's a rhythm to it. It's all about rhythm. So you've got to have consistency. You can't have a massive lie-in on a Sunday morning and then expect to be back in the groove to go back into your normal work or sleep pattern. Sorry, I know a massive lie-in on Sunday morning is brilliant, but if you have a sleep problem, you cannot do it, basically. And then, of course, there's the quality of sleep, and we have to think about the quality of sleep. So snoring, sleep apnea have a huge impact on quality of sleep, and drugs, by which I include caffeine, also and alcohol have a huge impact on sleep quality. So that's the sort of conversations that we have. We don't really have conversations. I mean, I record the duration of sleep, but it's not my main focus. It's the quality and the effectiveness of sleep that is most important. And you can tell from those few remarks a lot of the things that we advise. We advise consistency. We advise going to bed so that you're rested the next day. We advise looking at the quality of sleep and avoiding the things that reduce the quality of sleep. We make referrals to ENT and so forth, and we do use medication to help sleep sometimes. Mood. Now, obviously, this is complicated because if you're saying, well, improving your mood improves your well-being, well, of course it does. But it also, I think, particularly, there is a combination of poor mood, particularly anxiety and ADHD, that really is they kind of get into a vicious cycle, and they are more they affect your well-being much more combined than they would individually. So there's a kind of meshing there. And some of the most difficult cases that we look after in the service, and it's not difficult for me, it's difficult for the families, and it's difficult for the young people themselves. The people who have most difficulty are the people who have that combination of ADHD and anxiety, particularly, and later in life, and ADHD and low mood, obviously, because those are quite high risk people. So definitely addressing mood. And one of the things that gets missed when a child, particularly a young boy, is aggressive or very kind of lashing out a lot or very oppositional, is their anxiety gets missed. And so that's something that I do talk about a lot. So it is a component of management. It isn't something that will kind of immediately solve things. And of course, other things will feed into your mood. You can't use it in isolation. So better sleep will improve your mood. Better exercise will improve, more exercise will improve your mood. And of course, the general support. So it's not something that you can look into in isolation, but it is definitely something that we need to address. The question is, what is available to address it? Now, again, we go back to this whole thing of what's evidence-based versus what's actually helpful. And those are not the two same things. So CBT, cognitive behavioral therapy, is by far the best evidenced treatment for anxiety and depression, no question at all. But that's the evidence, which is short-term, relatively superficial measures of, has your anxiety got better, not has your life got better. Other therapies which take a broader view, so we're talking about psychotherapy or DBT or all of those other things, are probably in some ways deeper and get more to the root of some of the issues that you might be having, but they're not as well evidenced because the evidence base doesn't suit the way that they work. Now, I have some bias here because my wife is a psychotherapist, or about to be a psychotherapist. So I really have it's very difficult. We have interesting conversations about, well, there's no evidence for this, but we know it works because we do it on a personal basis, and the person tells us it works. That's very difficult from an NHS point of view in turn, because the NHS only commissions things that have evidence base in that narrow sense. So it's tricky. This area is really tricky. CBT, if it works for you, great. If it doesn't work for you, then it can be difficult to know what else is going to help. And just interested to note that the medication for ADHD, yes, of course, if your ADHD is better, then your mood can improve. What about these other things? So if you look at, I've looked at a few things, particularly around Facebook. What are the other things that people suggest, which are not drugs, which are supposed to be effective for ADHD? Diet, supplements, mindfulness, and biofeedback are the things that sort of come up. And I was just thinking about this, and I was sort of slightly skeptical kind of moment, really. Basically, there is a curve. If something gets developed and tested, the initial results are almost always really exciting, partly because if the initial results were not exciting, they wouldn't get published, and partly because the initial results is often on quite small samples, and it's very easy, just statistically, to get a really impressive result on 20 people. If you start, and then you start ramping it up to 2,000 people, and then you also start, I'm getting distracted by the comments, sorry. You start ramping up to 2,000 people, and you start being kind of more robust about it, and kind of more of the kind of randomized controlled trials. In all conditions, the impressiveness of the research will decline over time. That is just what we expect. Unfortunately, for these particular aspects, diets, mindfulness and biofeedback, the drop in the impressiveness of the research, again, by the specific lights of what evidence counts as evidence in the NHS or within science, has dropped off pretty quickly. One of the problems I have is that what's remained high is the value of these to marketers, people who want to sell you a treatment or sell you something. And that's marketers' job. It's fine. But the fact that people have said it's been shown in science to work, it's not that much better than a L'Oreal commercial, to be honest. If it's not actually made it to professional guidance, it probably, we don't know that it works yet at a population level. If it works for you, great, brilliant. But we as doctors cannot recommend those things because we don't have the strength of research to actually be able to make those recommendations. So just to reiterate, these are likely to be helpful for some people. The problem is we cannot predict at this point who it's going to be helpful for. I think the classic example of this is mindfulness. Some people really benefit from mindfulness, and there's no question that specifically mindfulness is the thing that has helped them. I'm not questioning that for a moment. But other people with ADHD try mindfulness and they hate it, but they persist with it because they've been told it works. If it doesn't work for you, it doesn't work for you. Stop it, please. Because there's no, whereas if you've got something which is more evidence that, yeah, you're likely to get this effect, you can push through a little bit. But with these things, if it's not working for you, please stop pretty quick, because you're probably in that group within whatever study that you've done, the group that for which it doesn't work. And it may be that we come back and we get subgroups. So mindfulness might work for people who have ADHD and particular personality traits. Great. Then we can be more focused in our recommendations. We'll see. I see that people are having a go at IAPT. Yeah, I don't disagree. So support at home. So this is, I think there's probably been mention of this already in the conference, but peer support I think is so important. One of the things I am proudest of in Lambeth is that we have a pretty active peer support network, and I will always recommend that families join our peer support network when they are when the child is diagnosed. Because I've got 20 years of experience in ADHD, and I have ADHD, but I don't necessarily say that in clinic. The peer support network has centuries of experience between them of being a parent of a child with ADHD, and all of the situations that this one particular family in front of me are in, somebody in the peer support network has been in it. So why would you not plug that in? The second thing that is quite helpful, and I know I've had a bit of a go at psychoeducation, I think we have some workshops and webinars in Lambeth, and I think if you can get onto a webinar, I think it's important that it's live, that you get the opportunity to ask questions. I'm not a big fan of just having stuff just watching something and not being able to ask anything about it, because I don't think it's very engaging. And where do your questions go then? So we're lucky we've got those locally, but if you haven't got stuff locally, you may need to find something from one of the organizations. And of course, ADHD UK has very regular meetings for a donation on every single subject you can think of related to ADHD. So that's one of the things that we in ADHD UK are most proud of. And then there are formal courses and support. And as a parent of a child with ADHD, you may be groaning a little bit at this point. You may have been onto a sort of parenting course, or you might have been offered a parenting course and been a bit offended because you're a good parent. Why would you need a course to do this thing that you're doing? And I just want to pause to explain why I think parenting courses are valid. And by the way, I have done one. If you think about these three rows of an exam hall. Okay, so let's say, for example, that they just, I wouldn't put it past the government, but there you go. That they change it so depending on what row of the hall, column of the hall, just for your pedants out there, there's a different pass mark. So this row has a pass mark of 90, this row has a pass mark of 60, and this row has got a pass mark of 30. They could basically go home, can't they? And that would be grossly unfair and a national scandal. And of course, the government won't do it because they won't. But that's what it's like in parenting. Some people can be, if you think about your parenting mark, how good a parent you are, most people, and I am parent 3, are most of the time about 60%, 50, 60% a good parent. I mean, last time my daughter was trying to talk to me and I was playing on the PlayStation and I did not feel like a good parent. I had to say, I'm really sorry. Was not listening because I was dying horribly. Please say again. So it wasn't a great parenting moment. She was a bit annoyed. For most people, and that's fine. And she has got ADHD, but she's cool. But for particularly a child with additional difficulties alongside their ADHD, a lot of the time your pass mark for your parenting is 90%, and that is grossly unfair. You will have friends whose children are really easy and their pass mark is 40, 30%. Even they could do whatever they like and the kids will still be fine. You are on a real knife edge as a parent of a child with ADHD, but there isn't any alternative. You don't want to not be their parent. So therefore, you have to raise your skill level and your confidence level to 90%. And I don't know if people find that helpful. I find it helpful talking to people in clinic. So that is why you might need parenting intervention, not because you are not because you wouldn't pass a normal exam. It's that you're basically you're being asked to be a super parent. And how can you be a super parent without training? It doesn't make any sense. You haven't, you're not Superman. You haven't got. How does Superman get his powers? It's just Krypton, isn't it? I don't know. Can't remember. You know what I mean. You haven't been bitten by a radioactive parenting spider. I'm on safer ground with Spider-Man. Right. So what's the point about parenting? So parenting support groups should be facilitated groups. They shouldn't be chalk and talk. They should be you as a group learning together. And there is really, really good evidence, excellent evidence. It's actually one of the most cost-effective interventions for mental health that exists in the world. For oppositional behavior and for parental stress, really good evidence for reducing those things. But it does not reduce your ADHD symptoms. To go back, the brain focus doesn't make any difference to your ADHD symptoms. Okay? Right, good. So actually sometimes I say, well, you've got lots of ADHD symptoms in your child, but actually he's not oppositional and you seem to be managing. I wouldn't worry about this yet. Do it later when it's time. There is a little bit of a kind of tendency amongst doctors to say this is the treatment. But it's not. It's a treatment for a set of difficulties which are really common in ADHD, but are not ADHD itself. Just to say. Oh, why is my... Oh, okay. Support at schools. There's a few things. There probably are some school teachers on the call. They usually are people who are in the education sector. So this is not a slide which is having a go at schools. I absolutely love my local schools. I think they do a tremendous job. But there are 3 things that are important to say. One is ADHD is a specialist educational need. So if you have a diagnosis of ADHD, you need to be under that system. There's no question about that. And people have pushed back and said, well, he's bright, or, she's doing really well. No, it's a special educational need. It requires you. You may not need anything right now, but it means that you are in that bracket. If what that makes the school have a duty is to make reasonable adjustments. The school therefore needs to make reasonable adjustments, and that's a duty in law. No question about that either. The question, of course, is what reasonable adjustments means. And in classic British law style, it's left a bit vague. And reasonableness is actually a really interesting legal topic, but we don't talk about it now. Basically, it's what a reasonable person would think is reasonable, which is kind of circular, but there you are. So schools will, that's where the kind of grey area is, and that's where the push and pull comes, is what is reasonable for this child in this school to as an adjustment to them. And there's we have all sorts of discussions about that, and that's where goodwill and working together becomes really important. It's really, really important to have an understanding, a little bit of an understanding of the funding arrangements for schools when you're trying to get help for your child. Schools sometimes are naughty. None of our schools, but other schools are naughty and say, we don't have any resources. They do. They had delegated funding for special educational needs from the local authority. They may not have enough, but they cannot say they don't have any. What they need, if the other thing that people talk about a lot is getting an EHCP. Again, we don't have time to talk about that in detail, but basically, if the school have exhausted their delegated funding allocation and the child is still not making progress, by which I mean also being in class, not just academic progress. So if they're getting excluded a lot, they're in all these dreadful kind of reflection rooms that the secondary schools send them to all the time, that is not making progress. That's not accessing learning. If they're not doing that and the school have put everything in, then the child should go forward to an EHCP. This process, however, does need to have at least the support of the school. And the really tricky bit is where the child clearly needs it, but for some reason the school won't go down that road. But that doesn't happen very often in Lambeth because our schools are fab. Then I have to say, I don't see adults in my clinical practice, but I am an adult with ADHD. So I guess I have a little bit of an insight here. So at work, a few very, very short points about that. One is reasonable adjustments. Again, the same principle of reasonable adjustments applies in work. You don't have to apply for reasonable adjustments. Your employer has a Lambeth has got its downsides, Mrs. Robinson. They've got some reasonable adjustments is a duty of your employer, whether or not you apply for them or not. That's what they have to do. That's a law thing. Access to work is a grant for specific things that you need for your work to work effectively. So it could be equipment, it could be training, it could be mental health care. Access to work seems, from what our experience, to be a pretty good scheme, I have to say, and people have got some really quite helpful things out of it. So I have a go at the government where I need to, but actually this seems to be a pretty effective scheme. And there's obviously personal independence payments. I think, again, to be fair, the disability benefits system is built for 40 years ago and now is dealing with a very much larger number of people and a very much broader definition of disability. So there are genuine difficulties, but also I have huge sympathy for people who are just trying to get a little bit of money so they can live their life, so they can get to work, and they're being bound up in quite a difficult situation, quite a difficult system. There you go. That's me being even-handed. So those are my things. Those are my sort of 4 things before medication. And so then when do you try medication? Well, the answer to that is once you have got the environment as good as it's going to be, not to perfection, not to the ideal situation of everyone being completely on side and all of the support you can possibly ask for, and 100% great patient parents, almost like robotic in their calm and their consistency. That's not going to happen. But as good as you're going to get in this situation with these people and that school, then I think you can have a think about meds. But I don't think you should do it unless you are in a really bad situation. I would say you don't do it until you've done those things. That's my particular view. And some people, have different views, and that's absolutely fine. But that would be my kind of view on this. Okay. I'm not quite finished. So I'm just going to do a summary, and then we've got some time for questions, which is marvelous. So we need to treat the person, and not the ADHD. So the brain is part of the person, so medication is part of that. But I think focusing on I'm treating your ADHD is the wrong focus. I think we're trying to make people's lives a bit better, a little kind of nudging a few kind of inches at a time towards something a little bit more functional. So that's the first thing. And the second thing is to try and surround yourself with understanding and surround yourself with love, really. Find people around you who get you, a teacher who gets you, a boss who gets you, anyone, friends who get you. It's really, really important to have those people in your life. And sometimes you need to leave things and leave relationships or leave schools or leave jobs if you don't have that understanding. And that's really, 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 really tough. Do think about optimizing your brain health, but don't get sucked into things that are making claims if they don't work. I mean, try stuff, by all means. Try stuff, try a supplement, try mindfulness, whatever. But if it doesn't work for you, let it go. Having said that, exercise, sleep, and mood are really well evidenced, and you should always focus on them. And then try and get as much support from around the place as you can. So think outside the box. Try and get support for, apply for access to work. Join the ADHD UK groups. Connect with other people. Peer support is absolutely vital. And those are the sorts of things. I mean, some very, very basic stuff, but those are the sorts of things that we genuinely talk about in clinic, and it seems to be what works. Okay, so we've got some questions. I found that back when Twitter used to be fun, not so much a question, more a comment. I mean, I think a lot of the things that people have put up are comments, and that's fine. I'm not really kind of aiming that at this audience. And if you have questions, there's my email. I can't really answer clinical questions, but if you've got anything else, that's fine. And I'm still just about on Twitter, but not really. Okay, should we have a chat again, Henry?
I'm back. Yeah. Hello. That was wonderful. Thank you, Max. I thought that was. You can see obviously all the comments coming in there. I thought it was fascinating and really important. So thank you. Now people can put in questions into the chat, and we'll look through them. They go into the stream. You can also look through, if you put it on, go to globaladhd.com, you can see, you can post your questions there. So please do that. What do you think of, so we've had a question around medication someone submitted. Is there any evidence on long-term effects of medication on children, i.e. long-standing implications?
I think there's two kind of ways to approach that. One is, what is the long-standing effect on brain structure if you take a group of children who have not had medication versus those who have? And of course, we have the limitation that at this point, we're not randomizing people to take medication or not medication. You can't randomize a group for 2 years or 3 years or 5 years. It's not ethical, because then people don't know what they're taking. You can only do that for a short space of time. So after that, you look at brain, you look at brain structure. And so there's the thing called the cortex, which is the kind of, in a sense, the kind of thinky bit around the outside of your brain, much of which is in the inside of your brain is more kind of tracts connecting the other bits, and the kind of emotional seats of the brains. The cortex of people who take medication is thicker than those who don't take medication. Okay, so that's encouraging. A thicker cortex is generally a good thing. And then you think, well, okay, what about functionally? People who take medication over time do tend to have better executive function, for instance, so organization and planning. And the other thing that's always slightly impresses me is that, so like in Scandinavia, they have these huge registries of basically everyone in the country, and they look at people with ADHD, and then they look at people who take medication versus don't take medication. And the people who take medication, for instance, have half the levels of involvement with the police, by which I mean getting in trouble, not joining the police. And so, I mean, that's impressive on its own. Of course, you need to have a little bit of caution in interpreting all of that, because there's lots of differences between the populations, which are not just whether they take medication or not. There may be lots of other factors of people who are dropping out of the health services, who have other issues, so they can't keep up with their medication. So it's not just a medication effect, but nonetheless, I think overall, we've got to be cautious, but the evidence for long-term effects of medication is mainly positive. I knew I was going to be asked about medication when I give a talk about non-medication. It's like the elephant in the room. Don't talk about elephants. Give a talk about not elephants, Max. Okay, I'm going to get questions about elephants.
God, well, I'm joining this fray. What about height for kids taking medication?
There is a small effect on height. No, it's a good point. There's about a 1 centimeter effect on height at a population level. Individually, that is obviously going to be more of a concern if you start early. If you start a 6-year-old, then you're probably going to get a bit more of an effect on height than 1 centimeter overall. We do monitor height, and I have to say we don't usually have a problem. I think maybe because I tend to give less than other people. But obviously, if you're starting a teenager or an adult, it doesn't really matter because they've done most of their growing already. But yeah, 1 centimeter height is a adverse effect. I mean, it's easy for me to say because I'm 6'3". I wouldn't miss 1 centimeter of height, but
I'm 5'11¾".
Yes, I know, Henry.
I'm bitter about that last word.
I think we've been talking about your height for about 30 years. So anyway, you just have the misfortune of having tall friends.
It's true. They can get things off high shelves for me. It's actually it's a pertinent question because a friend of mine who is significantly more vertical challenged, his son is really worried and actually is not taking medication because he's so worried. Like genetically, his genetic request is clear, and so that centimeter means a lot. And yeah, why do we know why height is impacted at all?
That's a really great question. I don't think we know exactly. I think it's something to do with the way that the medication might have an effect on metabolism. And I think it might sort of route things from growth to other aspects of metabolism by the stimulant effect. I think the honest truth is we don't really know. And I suppose because it's only 1 centimeter, we're sort of not really.
Yeah. But like
we're not really kind of looking into it in a huge amount.
Yeah, I think the issue is though some children are, right? And there's I do think this is not for you, Max is not in charge of all research into ADHD in the country and the world, just to be sure. But I think more
not yet. Nor am I ever going to be
working on it. I think actually so that people can make clearer decisions, so they have really good data, more research there would be useful. We've had some questions on supplements. We've had two, which is nice. So one is much more simple, which is what supplements would you recommend for ADHD? And the is more detailed. Are magnesium supplements a good option? Are there any negative effects to taking them in general, like there is for calcium ones?
So I suppose just to reiterate what I said in the talk, we don't recommend supplements, not because we think that they're terrible or bad, but because we don't have good enough evidence at a population level that they work. If you try it and you find it really helpful, great, good for you. But firstly, most people I know who I look after who try supplements, it doesn't really work. And also, we don't have the evidence is that if you look at the whole population, there isn't an effect at a population level from supplements, because the problem you've always got if you take something as part of an overall management of your ADHD and you feel better, well, how do you know that it's the supplements that make the difference? If you're quite robust about it and you try one thing, you change one thing at a time, you might have a bit more of kind of confidence in knowing that that's the thing that's changed. But I'm a bit wary about it, partly apart from anything else. They're quite expensive, and the families that we look after don't have a lot of spare cash, and I don't know, maybe you use it to have a membership of the swimming pool. If you've got a little bit of spare cash for your ADHD, go swimming. For me, or buy a bike, whatever. Those are the things that I think are much more important.
We have had a question. Are there any non-medication? So you'll be glad to hear we're moving into non-medication. Any non-medication recommendations that could be suggested for adolescents when they experience hormonal changes, and how these might affect their ADHD? And I think when we've been talking, we've had groups where we're doing ADHD in women, and there's a growing group of people talking around medication altering during a woman's cycle, that there's a different impact. We need to think about having slightly different levels during it. And so this hormonal impact, I think, is really interesting. Okay, over to you.
Yeah, I mean, I think there's a specific thing about the menstrual cycle, and I just have to declare my ignorance. Really, I don't know enough about it, and we don't yet have recommendations about how to manage the menstrual cycle in the concept in the context of ADHD medications. In terms of, I always ask people what they mean when they say hormonal changes in adolescence, because often what you mean is that often what is meant is the child's behavior has changed over a course of months as puberty goes on. Puberty kicks in, but actually puberty is not just hormones. Puberty happens at the same time that there's a huge change in their life going to secondary school. Their social roles have changed, their friendship groups have changed, their brain is changing, admittedly somewhat under the influence of hormones themselves. So when you say hormonal changes, what's meant is, my child has become a teenager, what on earth's going on? And I think honestly, the recommendation I would make is to sort of learn more about teenagers, and possibly if you've done a parenting course before, see if there's one specific to teenagers locally, even if it's not specific to ADHD. But understanding and getting and connecting with teenagers is a really different job as a parent to understanding and connecting with younger children. So honestly, I would go back and review your relationship with your child and the way that and look at the way you're parenting and whether that's better. Whether that can be improved. But in terms of so there's a menstrual cycle, I don't know, and puberty, I don't think it's supplements that you need. I think it might be just setting back.
I don't, yeah. Someone's gone into that, actually. We've had an additional question. What are the best strategies for children with ADHD to manage their moods? And they've talked, my biggest issue growing up undiagnosed was mood. It was a lot of yelling and anger, and I felt anger management didn't help.
I didn't hear all of that, Henry. Sorry. I think I don't know if it's just me. You're breaking up a little bit.
I hope it's just you. What are the best strategies for children with ADHD to manage their mood? My biggest issue growing up undiagnosed as mood. It was a lot of yelling and anger. I felt anger management didn't help.
Yeah. So, I mean, I don't think they've got good evidence for anger management as such. And I think basically because there's nothing wrong with anger. Anger is not something that we should try and control or reduce. It's just something that we should think about what we do with it and how we respond to it. And the other thing that the person said, which is absolutely key, is that she got undiagnosed. So, if your mood's being treated but your ADHD is being ignored, you're only treating half of, at least, at best, half of the difficulties of the. Of course, you're going to have these. So, to answer your question at a base level, what are the recommendations for mood in ADHD? Obviously, diagnose the ADHD and manage the rest of things, and then be alert to the fact that this angry, shouting person might be anxious, and that they're not just angry and shouting. That what is the internal life of that person? What's going on for them personally? Just having that curiosity, and then if they do have an anxiety problem, then seeking appropriate treatment for it. And I know that the treatment, particularly in the UK, is not adequate, and the availability is not adequate, but that is where we're at, and that's what's available.
Thank you. Someone's asked, they've asked multiple times, does prematurity increase the likelihood of ADHD or autism? It's not quite
prematurity. Yeah, I saw that question. Just posted it a couple of times. Yes, 100% it is. Prematurity is two things to say about prematurity. The slightly premature baby, sort of 34, 35 weeks, so that's about 5 or 6 weeks early, often has fairly classic signs of ADHD to lots of kids. And what happens is that they get to their 2-year check, and the doctors say, yes, you're fine, off you go. And then they arrive in kind of reception, and they're kind of a bit all over the place. And then they come and see us. So that's quite a typical pattern, and they have reasonably typical ADHD symptoms, and definitely more of it than the general population. So they should probably be, I would argue, they should be screened when they go into, they should be tracked and screened when they go into reception. The very premature, so when you get down to 20, when you get premature, when down to 24 weeks, at the sort of the extremes, they tend to have, obviously they may have lots of difficulties with learning disability, but even, you go up to 28, 29 weeks, you've got problems. Therefore, you tend to have a mixture of things, a weird, strange mixture of some ADHD features, some autism features, atypical features, things that don't really fit in with the diagnostic categories all that well. And so you often in those groups have to kind of work around the just kind of describing the features and managing things in a pragmatic way rather than trying to fit them into your diagnostic boxes. There's a really interesting the comeback is, how is this a genetic condition? No one is saying that this is a straightforwardly just genetic condition. That's not true. What it is most of the population risk for ADHD is the genetic loading. For this small population of people who are premature, they might not have had ADHD, but then they were premature, and that's what triggered their ADHD. For the majority of the population, the heritability, i.e. the contribution of genetics to their ADHD, is something like 70 or 80%, depending on the study that you.
I was about to. I think so the one I quote is 76%.
Yeah.
So yeah.
So, but for that, but that's at the population level. In this subpopulation, it's not genetic. It's caused by prematurity. Equally, kind of, if you have a head trauma, that can induce some ADHD symptoms. But it is not true, and I just want to push back against Lucy here. Trauma is not the only cause of. Sorry, hang on. You said that you're not actually. You're not actually. There's some really inappropriate stuff going on. Please
there really
go away.
Is. Okay, we'll do
but just to answer Lucy for a moment. Just to answer Lucy, I just understand. I read your comment properly. I think that the evidence for trauma causing ADHD, the jury is still out as to whether trauma, as in emotional trauma, can contribute towards ADHD. And I think it's definitely an open question. It doesn't mean that 70% at a population level does leave you a window for environmental factors to be important. We don't have the evidence so far. What I would say is that I suppose, to go back to my little kind of graph, if you can remember it now, for a given level of ADHD-ness, if you also have experienced trauma in your life, your brain health is going to be very much worse, and so therefore your impairment for a given level of ADHD-ness is going to be very much worse, and you're quite likely to be in a less positive environment if you're previously traumatized, because that's just how these things track. So I think it's a really complex issue, and I definitely think that that examining the trauma history in a child who has ADHD can be helpful if something can be done now. The problem with I'm not saying anyone is fixating on trauma histories, but the problem with kind of trying to find a cause in trauma histories is that maybe something really bad happened to you in the past. That may or may not matter for what you do now. If you're revisiting it and it's conditioning your responses, yeah, address that. But if it's just something that was a bit rubbish and now you've moved on, you don't have to dwell on it. I suppose that's the pragmatic way forward.
Max, that's been wonderful. Thank you so much. Thank you for being my co-founders. And all you're doing in the charity. Lots of people don't know how hard works within the charity and all he does. That was a wonderful talk. Thank you so much. Thanks for answering all